All right, we're going to talk about traumatic brain injury and CVA. We will talk more about CVA in Chapter 19, which is about support systems, the circulatory and CSF systems. And the circulatory system, of course, is very involved with stroke. And you will also talk about it way more in neurorehab class next quarter. Traumatic brain injuries, spinal cord injuries. So a lot of the things we've introduced in this class, they're continuing on. You're going to hear more about them. One symptom that can be a symptom of, it's often a symptom of stroke and sometimes of traumatic brain injury. I meant to discuss it in the communication chapter near neglect because it's a similar effect, but it's called lateropulsion, also sometimes called pusher syndrome or controversive pushing. It's where the patient pushes pretty powerfully away from the less affected side in sitting as well as during transfer standing and walking. So they're pushing towards their more affected side. They extend their unaffected or less affected arm and leg and push, and it creates a really high risk for falls because they're pushing themselves onto their weak side. Patients that exhibit this behavior are extremely resistant to attempts to adjust their posture and passively into a symmetrical position. So if you try to push them back, they will fight you. And so in Jamie's class next quarter, you'll talk about some strategies for dealing with that. And it can be a real safety issue, and for you and for them. And so, a lot of times you're trying to work on transfer, standing, walking, even sitting balance, and the pusher syndrome or lateropulsion can be a real problem. Okay, so we'll talk about traumatic brain injury, and we're just going to talk about it briefly, and then you'll get more of it next quarter. So the majority of moderate to severe traumatic brain injuries occur in motor vehicle accidents. That makes sense. That's where you're getting a lot of force. There's been a lot of talk in the sports medicine literature in the last couple of years about progressive or continual brain injuries that happen in impact sports, and people end up with cumulative brain damage. So that's kind of interesting. It's an interesting area. We are not going to talk about it, but it's still interesting. So impact from a motor vehicle accident tends to damage the orbital, frontal, anterior, and inferior temporal regions and cause diffuse axonal injury usually from blood being loose in the brain from the injury. So a lot of times if you get traumatic brain damage in infants, frequently attributable to accidental falls, but usually most falls are relatively minor with infants. They don't weigh very much. They can't produce enough force to produce traumatic brain damage. But usually to get a severe brain injury in a child that small, it requires greater force than typical fall. Like shaken infant syndrome is a brain damage thing. It's a traumatic brain injury. Trauma from shaking, it's the impact from the brain striking the skull repeatedly. So that is a common, unfortunately, when you get traumatic brain damage in infants, that's commonly the cause of it. So in the book they have the nice little pathology chart like they usually have. So the pathology is diffuse axonal injury, contusion, hemorrhage, swelling, and or laceration of the brain because of trauma. It's an acute onset, obviously. There's usually something that people can point to that happens, like a fell off the roof or a car accident or something like that caused it. So signs and symptoms, there are a lot of personality things that we talked about a little bit in the last section. Decreased goal-directed behavior, decreased executive function, impulsiveness, inappropriate behaviors, low tolerance for frustration, emotional lability and delusions, slow mental processing, and decreased cognitive flexibility can be a cognitive effect. You can have impaired consciousness for a prolonged period, like being in a coma or being in a stupor. Or once they're a little more conscious, they have They're very distractible, have difficulty directing attention and attending to several things simultaneously. So because of that, a lot of times if you're working with someone with a brain injury, you want to work in a quiet place without a lot of distractions. So communication is often normal in people with TBIs. Declarative memory impairments might be temporary or prolonged, so they might be able to learn new information and repeat it back, or they might not. It depends on the extent of their injury. Their sensory perception might be impaired. You know, in the last section we talked about the different impairments to the sensory areas. If you have a brain injury in that area, you could have impaired sensory processing. You might have problems with autonomic regulation because of compression of the brainstem or the hypothalamus. There can be motor issues. You can get motor perseveration, repeating a movement over and over again uncontrollably. The degree of motor impairment depends on the severity of the injury, the paresis and paralysis, spasticity, contracture, balance, posture, gait, speech, swallowing, and eye movement disorders. So any of those are motor disorders, and they can all be affected with the TBI. Most frequently affects the anterior frontal, ventral frontal, and temporal lobes. Because in a car accident is the most common type of trauma, you hit the front of your head, sometimes the back of your head, but anyway, that's how it happens a lot. There's a nice video about a young man with a traumatic brain injury. I worked with a really nice young guy it was in a car accident. I think it was a motorcycle accident, but he had a traumatic brain injury, and he had some of all of these signs. He had decreased goal-directed behavior, a little bit of impulsiveness, but not too bad. He had some decreased cognitive flexibility, and a little bit of slowed processing. He had a pretty good memory. He could remember things. He was a little bit distractible, so you had to keep on that. His communication was good. He had a little bit of sensory and motor impairment. We did some work just on balance and gait and that sort of thing. We did some exercise in the pool, which was really helpful when you have sensory impairments. That water gives you some really good sensory input. I'm really big on aquatic therapy for neuro patients because I think it works really, really well in a lot of cases. So it's really interesting. This video is produced by the young man's mom, and it's touching. I like it. It's a good video. So then we're going to talk, just sort of introduce the idea of stroke, and then we're going to go more into it in the next chapter, and then you'll get even more in neurorehab next quarter. So a stroke, or cerebrovascular accident, is the neurologic outcome of an interruption of the blood flow to the cerebrum. The outcome depends on the cause, location, and size of the infarct or hemorrhage. Infarcts occur when an embolus or thrombus lodges in a vessel obstructing blood flow. Hemorrhages occur, you can have an aneurysm that bursts, or an arteriovenous malformation that bursts, and that can cause hemorrhagic stroke. So the most common type of stroke is the ischemic stroke with the thrombus or embolus. The hemorrhagic stroke is less common, and you'll see both types. So the signs and symptoms are going to depend on the location and the size of the lesion. So a small insult to the cortex might produce no symptoms, whereas the same size or smaller lesion in the brainstem could cause death. So it just depends on what area is affected, really. Large hemorrhages or edema, when you get swelling to the brain secondary to large infarcts, can cause death regardless of location because they can compress vital structures. So the hemorrhagic strokes are there. It's far more common to die from those than from ischemic strokes, just because of that edema and the large damage done by the hemorrhages. So even though they talk about hemiplegia and the affected side and the involved side and the uninvolved side, usually they often appear unilateral because they're worse on one side, but saying the uninvolved side is kind of a misnomer because really both sides are often involved. You know, we've talked about a little about the crossover and whether it's the contralateral or the ipsilateral side, and when you were doing your spinal cord case studies, you saw a lot where there are effects on both sides, they're just different effects. And so we talk about the uninvolved side, but it would probably be more appropriate to say the less involved side. Or you could say the motor involved side and the sensory involved side or something like that. But both sides, there's often an effect on both sides with the stroke. So when you're recovering from a stroke, a lot of times we use compensation to, you're going to try to perform tasks using the more motor affected limb, or an adapted approach, or using the non-motor affected limb to perform the task. Remediation is an attempt to decrease the severity of the neurologic deficit. So that happens in the acute setting. That's when they give them the TPA, the clot busting drugs. They're trying to decrease the severity of the CVA. And that's important because you want to have the least amount of damage possible. There's a motor control approach to recovery where you're emphasizing specific tasks. We talked about that a little bit in the neuroplasticity chapter. You're practicing a desired task in a specific context, and you're working on motor control. So there are a lot of different approaches to stroke rehab, and they all have their benefits. You know, it's kind of interesting. Probably no matter what in therapy environment you work in, you're going to run into somebody who has had some form of stroke. And I love working with CVA patients. It's one of my favorite areas of therapy because you can do so much for people to improve their quality of life. It's really quite cool. So you're going to have some different signs and symptoms versus whether it's in the left hemisphere versus the right hemisphere. And a lot of times you'll have some different behavioral signs. So in a left hemisphere stroke, you're going to have hemiparesis or hemiplegia or hemisensory loss affecting the right side of the body and face. Often there are language and speech disorders because Broca's and Wernicke's are in the left hemisphere. Difficulty understanding and or producing language, depending on which area is affected. Dysarthria is possible if the primary motor cortex for those speech muscles is affected. And cautious behavior, hesitant to try new tasks. So someone with a left hemisphere stroke, I don't know, they're not sure if they're able to do it. I was working with a guy who had they'll say a lot of times left CVA, right hemi. I was trying to get him to, I had a chair up on a mat table and it was against a wall, so the chair was up against the wall too. I was trying to get him to kneel on the mat table and put his hands on the chair. It was a new activity for him, and the new activity, he was very cautious about it. He was very hesitant to try that. But once we got him up there, being on the knees like that, and you're almost in a partial quadruped position, knees on the mat table, hands on the chair, it got him to shift his weight a little bit better, and that's what I was going for. But it was really difficult to get him to do it for the first time. Once he had done it, he was a lot better, but he was very cautious, very difficult to do it. Someone with a right CVA, so right CVA, left hemi is what they usually say. So they have the hemiparesis or hemiplegia or hemisensory loss affecting the left side of the body and face. They often have left neglect. So this is the person that you have to make sure to tell them, pick your arm up. Don't don't let the arm hang down there, because they're just completely ignoring that their left arm even exists. They tend to be more unaware of their deficits and have impulsive behavior. So they will stand up before you're ready, so you got to be careful about that. Sometimes people, after a right hemisphere stroke, they'll say, oh, I can drive, I'll be fine. And this is bad because they have that left neglect. They are not attending to the left side, and they can be a menace out there in a car. So sometimes, a lot of times, people with a right hemisphere stroke, depending on what is affected and the extent of the damage, they regain their walking more easily than a person with a left hemisphere stroke. So a lot of times they make errors in memory, and they're kind of disinhibited. They have that impulsive behavior. So they might tell you stuff that might not be true. So that's a little more common with a right hemisphere stroke than a left hemisphere stroke. The language is intact, and they have, fluent language. So you might think that they're more capable than they really are. And so they might say, oh yeah, I can stand and walk and drive by myself. And they really can't. But a lot of times they can't comprehend the emotional content of speech. They're not relating to other people as easily. I worked with this one really nice lady who had a right CVA, left hemi. She actually had good balance. Her walking was good. At first she was walking with a walker, and then she was walking with a cane, and then she was walking in very short order, walking without anything. But oh man, if anything was on her left side, she would crash right into it. And then, didn't care. She'd go right on. And so she was, her balance was good, though. We did a lot of balance activities, and I was actually amazed at how well she did. And she had normal conversational style and everything. So that's that thing where you might think they're more capable than they are. So she said, well, I really want to get back to driving because my husband can't drive. He's got dementia. And I'm like, really? So the husband came in. The son brought the husband in one day. And I thought, oh yeah, he should not be driving. And he didn't think so, though. He thought he was okay to drive. And she shouldn't have been driving, and she thought she was okay to drive. And honestly, I don't know what was going on with the son, because it wasn't any of my business, and I didn't ask. But I don't think he should have been driving either. So nobody in the family really should have been driving. So just when you're out there driving, remember there are people out there who think they can drive, and they really can't. A little bit scary. So there's a video that talks about the effects of left or right CVA. I don't know if any of you have read My Stroke of Insight. There's a brain scientist. Her name is Jill Bolte Taylor, and she had a right hemorrhagic stroke about 15 years ago. She recovered. I mean, it took her years and years. She had a very complete recovery. And she wrote a book called My Stroke of Insight, and it's a very good book. It's has a lot of an anatomical detail. It gives you tips for dealing with people with a stroke and dealing with your loved ones if they've had a stroke. Really, really good. I would highly recommend reading it. It's an easy and entertaining read, as well as very informative. In this 20-minute video, it's one of the TED Talks. She describes what she felt like when she was having her stroke. It's very interesting. So if you have time to watch it now, that's great. If you don't, watch it after the quarter's over, because it's really interesting. Just because she's had all this time now to recover and process what she was feeling, and because she was a brain scientist to begin with, she was kind of, as it was happening to her, even though she was kind of out of it, she was observing. She almost took the place of an external observer as to what was happening to her. Very interesting. So it's a great video, and really neat to watch. So for the assignment for this module, there are 2 files in the download, on the download page. One of them is called PTA student, and the other one is, let's see, I forgot what I forgot what I called them. One's PTA student and the other one is helper or something like that. Friend or family member, I think, is what it's called. Let's look, shall we? PTA student and friend or family member. Yes. So those are PDF files. When you download them, don't look at them. And what you'll do is one of the pictures your friend or family member will describe to you, and you will try to draw it. And the other one, you will describe it to them, and they will try to draw it. And it's kind of a fun activity. And then what I want you to do is I want you to go on the discussion board and talk about how the directions were difficult to follow. It might be because your person wasn't listening to you, or you described something that they couldn't draw, or something like that. And just kind of talk about that, the difficulties you had in communicating to the drawing information, and then imagine what difficulties someone might have if they were experiencing expressive or receptive aphasia. So after watching those videos on Wernicke's and Broca's, how difficult would it be to do this drawing activity with a CVA patient that had aphasia? And so what are some of the considerations that you might have to have when you're treating someone with aphasia? And it's really kind of a fun little activity, and I think at the end of the quarter like this, we really need a fun activity because it's been Stress City, right? So that's the assignment for this week, and I think hopefully you'll have fun doing it. And then, of course, there's a quiz this week as well. As usual, post any questions, and we will get through that. The last part of this material is going to be on support systems, and then we will be done with new material for the quarter. Pretty exciting.